তো আমি তো এখন একবার ওরা ট্রায়াল দেখতে চাইছি।
Good evening, everyone. This is Shagnik, the designated moderator from ClearNet for this session. ClearNet is very proud to be a part of this webinar as its digital partner. Here's a short intro video of ClearNet. One second. Huh. Thank you everyone for your patience. As you all know, ClearNet is India's largest live digital CME and doctors generated medical content platform, which is exclusively free for all the medical practitioners. You all are requested to visit our website www.clearnet.com, where you can watch lots of live sessions conducted by expertise doctors all across the globe. We even have our MedWiki, which is a service which is actually a medical Wikipedia for doctors only that you can read. We are very grateful to Cancer Kids Strength of Smiles Doctors Network and the star-studded panel with such highly affiliated doctors to be associated with us today on our platform. Now, without further ado, I would like to hand over this session to Dr. Monica Bhagat. Ma'am, if you may proceed.
Okay, I'll just introduce what is CancerKidsSOS. If I'll just take 1 minute for that. So Cancer Kids Strength of Smile is an NGO which is trying to help doctors to connect with diagnostic services. We are trying to have good academic sections so that cases can be developed, and we have recent advances which can be discussed later on further as we move further in our academic section. Then we have a connection with support groups. We are trying to connect with almost all the support groups which are present all across the India. So in case any patient is in any town in India requires help, we can get connected to those support groups so that patient is benefited and even doctor can complete treatment. Likewise, we're trying to connect with parents also who need support for the treatment of their child. So I'm actually very happy to announce Ekatrasetu lecture series, which is we're trying to get doctors together. So we are trying to come together to improve survival of childhood cancer in India. So Dr. Amit Kumar is a pediatric oncologist trained in TMH Tata Memorial Hospital, Mumbai. He's got good experience over 12 years in pediatric oncology. He is currently working in HCG Kolaba and Borivali, and he is going to help us know. He's basically going to tell us all the red flags which actually we should know when we see patients in our clinical practice. So whenever we have a doubt that child might have cancer, we should be able to pick that up. So he's going to tell us about those red flags. Dr. Amit, you can start your screen.
Sir, you're muted, sir. Wait 1 second, sir.
Is it okay? I'm audible?
Yes, sir, you're audible.
Yeah.
You can make the presentation full screen once.
Yeah,
So
yeah.
it'll be better to view. Yes, sir. Fine. Okay, sir. You can continue, sir.
Thank you, Dr. Monica, for introducing me, and thank you for connecting me to such a learned audience. and I hope this is a informative session for you. So I am going to talk about the red flags for suspecting cancer in children and how to evaluate. So coming to background, childhood cancer often is difficult to detect in its early stages because this has a very non-specific signs and symptoms that are incidence onset and may mimic variety of more common childhood illnesses that we find in normal infections with normal problems in childhood, normal diseases. So for an oncologist like me, the index of suspicion may very high, but for a pediatrician or primary care physician, the opposite is true. That is, even if they see these signs and symptoms, if they don't know, they may not think of diagnosing oncology, malignancy per se. So it's important to think about the possibility of cancer before one can actually make a diagnosis. So around 85% of cancers in pediatrics are associated with presenting signs symptoms that are common to other diseases, and rest 10 to 15% are actually with unusual signs symptoms that are more difficult to diagnose in the stages. When you see the incidence of cancers, if you see in less than 15 years of age, the ALL, acute lymphocytic leukemia, is the most common, followed by CNS tumors, and others are other leukemias and other RMS, neuroblastoma, and all. And as we go to adolescent group 15 to 19 years, we see that the Hodgkin lymphoma and NHL form the major part of the group, and followed by germ cell tumors and other germ cell tumors and osteosarcomas and all. So we should know this just because if we see a child, we should actually suspect what kind of cancer the child may be having. Like if a child less than 5 years present with some symptoms, then the first DD we should be having is ALL if the signs and symptoms support that diagnosis. So just to know this. So what are the signs and symptoms that generally a child presents with when he has some malignancy? The first and foremost is fever. Others are constitutional symptoms like weight loss, fatigue, pallor, lymph node enlargement, CNS symptoms, aches and pains like bone pain, back pain, and joint pain, a mediastinal mass, lump in abdomen, soft tissue mass, or some hematologic abnormalities. These signs and symptoms are not specific for this cancer, but these are the symptoms and signs that a child generally presents when he's harboring some malignancy. So we would go one by one with all these symptoms, and we'll see the red flags when you should suspect a cancer. Like for fever, then we can suspect this fever can be a sign of malignancy. Like so a fever that is unexplained. Like when we see unexplained fever, the fever that is recurrent, persistent for around more than 2 weeks, then we say this is unexplained fever. We have done the investigations that we usually do, but we are not able to find the answer for that. Though when we search the literature, then we can see that even in unexplained fever, just about 5 to 10% of them are actual malignant fevers, and others are the other common illnesses like immunological one, and they don't have malignancy. So if a fever that does not follow the usual course, unresolving, recurrent, or fails to respond to seemingly appropriate therapy, we should suspect malignancy. Additional findings of lymph node enlargement, hepatosmegaly, or any bleeding symptom like petechiae, purpura, bleeding from gums and either side, we should think of malignancy. Rarely, this fever can be secondary to tumor-related necrosis, like with neuroblastoma, Wilms tumor, and maybe the only complaint in child with leukemia, Ewing sarcoma, and Langerhans histiocytosis. These children may not have any other complaint, but may have just have indolent fever that is recurring on and off. So what we should do in these cases, actually, when we have been exhausted with all the primary labs that we do, generally we do PBS for this, just because we have to see the blood smear for any abnormal cells. We should do a culture of the blood or even bone marrow culture. We should do a chest X-ray, chest and chest imaging if required, and other additional testing that we do for PUO. What are the clues diagnosis that we can that can suggest that there is some malignancy? Like if there is subretic blast or profound neutropenia or thrombocytopenia, this can suggest a diagnosis of leukemia. So any fever with suppression or abnormality in the 2 cell lines in the blood, we should suspect malignancy. Finding of atypical lymphocytes may say a non-malignant condition like infection mononucleosis or other viral illnesses, but it can also be a malignancy itself. The other thing is the leukocytosis picture, that we see immature blood cells that are immature cells that are generally found in bone marrow. They are pushed into blood, peripheral blood. So this type picture can be seen when there is marrow infiltration by tumor cells like neuroblastoma, like Ewing sarcoma, rhabdomyosarcoma, and all. So if we see this kind of picture in peripheral blood, we should actually go for a bone marrow, and we should search the source for this problem. So CXR that we do for a PU or for a prolonged fever actually may reveal a mediastinal mass or lymphadenopathy that should be worked up. So other symptoms like constitutional symptoms are there. Like if that weight loss that is generally more common because of non-malignant etiologies like dehydration, infection, malnutrition, and pallor fatigue that are also common because of other illnesses chronic infection, rheumatic disorders, or heart failure, or arrhythmias, or any metabolic disorder. The red flag that suggests malignancy in these cases is like continued unintentional weight losses, fatigue or progressive pallor, when the child is when someone is trying to eat well, there is no history of dieting and all, he is not intentionally losing any weight, and still there is loss of weight and there is fatigue and progressive pallor. There is association of easy bruisability, bone pains or abnormal swelling, lymph node or enlargement of the organs, and unexplained prolonged fever, or when the other common conditions like COX and HIV have been ruled out. So these are the signs when we should actually suspect a malignancy. Then coming to lymphadenopathy, so when you see that the child is suffering with lymphadenopathy, when there is cervical and ganglion nodes greater than 1 centimeter, inguinal nodes more than 1.5 centimeter diameter, epitrochlear nodes more than 0.5 centimeter, and supraclavicular node if of any size is palpable. So mostly the nodes are enlarged in children related to infections only, like bacterial, viral, or mycobacterial. But when do you say we can say that this can be malignancy? Like when we see the pattern of the lymphadenopathy, a generalized lymphadenopathy is more likely malignant, except for EBV that may also cause this generalized lymphadenopathy. Regional neuropathy not involving head and neck are more likely malignant. Like head and neck region, we can see lymphadenopathy in many children because of this physiological growth of the lymphoid tissue in them up to even adolescents. And there is a lot of infections like throat infections, scalp infections, boils and all that may lead to the lymphadenopathy. But other than that, head and neck region, the adenopathy, if this is there, we should be more careful. Then if a lymph node is hard, rubbery, non-tender, matted, fixed and non-mobile, this node is more likely to be malignant. And coming to location, adenopathy in posterior auricular, epitrochlear or supraclavicular areas are more like malignant, and large adenopathy in mediastinum is frequently malignant. So other consideration that should come to our mind when we see a child with lymphadenopathy is association with systemic symptoms like fever more than 1 week, night sweats or weight loss more than 10% body weight, or associated splenomegaly, hepatomegaly, or hematologic abnormalities, we should suspect malignancy. Lymph node of more than 1 centimeter, that is 0.4 inches, with onset in neonatal period is always pathological. That is less than 1 month of age, any lymph node more than 1 centimeter is pathological. Lymph node of more than 2 centimeter in diameter, which has increased in size from baseline and have not responded to antibiotics, should be worked up. And any abnormal CBC and differentials with elevated LDH, we should suspect malignancy. So the urgency evaluation is determined by how sick the child is looking. Like if the child is looking quite sick, then the evaluation should be quite rapid. And if it is not sick, then it can be deliberate and we can give a course of antibiotics and see the response. So what do we do in these cases? Initial labs include CBC with DCTC, then ESR, CRP, LDH, serology of CMV and EBV, and for viral illnesses as validated by history and examination, we should do a TST to rule out COX and a chest X-ray is to be done. If there is generalized neuropathy, then we should also see the causes for this, like different infections like Bartonella, Hensley, Toxoplasma, Histoplasma, HIV, and all. And we should also screen for systemic vasculitis syndromes like SLE, GIA, etc. So when should we actually be suspecting more of this? When there is associated systemic symptoms like B symptoms, hepatosmegaly and all, and lymph node is increasing further in size despite adequate treatment that the child should be getting, and the lymph node of more than 2 centimeter diameter with either the following, like diagnosis remain uncertain even after 4 weeks of treatment, and there is no response to treatment as guided by initial investigation, that we should we should go for a biopsy. Indication of early biopsy, when do we do it? Like a child with general neuropathy with any of the following, with like supraclavicular nodes with massively enlarged lymph nodes more than 4 centimeter, or a group of nodes of total diameter more than 3 centimeter. So a node with a single node with size more than 4 centimeter and a group of nodes more than 3 centimeters should always be biopsied. Fourth is CNS symptom. What are red flag signs? So first is headache. A headache is said to be persistent if it is recurrent headache or continuous headache that lasts for more than 4 weeks with any of the following red flag signs. So that aggravates typically in recumbent position, results in waking up at night or is present on waking up in the morning, and it is relieved somewhat by vomiting. It diminishes over the course of the day and over time increases severity and frequency. That is, the child headache increases over time of maybe 15-20 days or something. And this is usually frontal occipital rather than temporal in origin. And if a headache occurs in a child less than 4 years of age, this is already pathological. And if this is associated with other symptoms like disorientation, confusion, or any signs of regurgitation. Then others are visual findings or eye findings. What are the red flags for that? Any new onset nystagmus, ptosis, or new onset paralytic squint, patridema or optic atrophy, or reduced acuity not due to refractory error or any visual field reduction that is seen in the child recently. So most important part is if a child comes to a pediatrician, we should always look for white reflex. That is the first sign of retoblastoma without any symptom in a young child. So the parents may just notice a white reflex, or doctor while examining just may notice a white reflex, and child being small may not be able to tell anything about a problem in vision. So it should be kept in mind that a child, if he comes to you, so in younger age than 3 years, a white reflex should be checked at least once. So what are motor findings in CNS? The red flags. Red flags, that is there is regression of milestones, there is focal motor weakness or abnormal gait and or coordination, Bell's palsy with no improvement over 4 weeks, or swallowing difficulties without any identifiable local cause. These are the signs that we should suspect there is some SO and we should investigate. So change behavior or school performance, sleep disturbance, and growth impairment, if noted in a child, school-going child, we should always suspect that there is something sinister going on. We should do an imaging. A child with so one more important thing is that when a child visits us, we should always look for AF and persistently open AF after 1 year of age. We may be a problematic thing, and we should always do a hair surface measurement in the child. And any nuance in macrocephaly in infants is a sign that there may be some space occupying lesion inside. So there are some many differential for this that are benign ones, and this should always kept in mind while thinking of malignancy. And most of these can be actually ruled out with imaging. So how to evaluate this? So first and foremost thing is we should do a proper physical examination and look for various localizing signs that may point toward the location of the SOL. Like cerebellum, like initial cerebellar dysfunction may be insidious with clumsiness, worsening of handwriting, difficulty in hopping and running, and slow or halting speech and ataxia. The hemispheric masses cerebellum may have lateralizing signs like such appendicular dysmetry or nystagmus, and midline masses will have truncal steadiness, unsteadiness, and increased ICP. CP angle tumor will have facial weaknesses, absent corneal reflexes, hearing loss because facial involvement, and optic nerve involvement. Brainstem will have long tract signs and cranial neuropathies and many others that may actually help to point towards the location of the SOL. So how do we proceed further? So any suspicion of SOL, we should go for a neuroimaging. Generally, CT brain is the first investigation that we do, and intracranial bleed or ischemic or embolic stroke or infection etiologies or structural anomalies can be ruled out with CT scan. If there is any SOL that is visualized in CT scan, we should go for MRI, MRI scan. That is good for visualization of the SOL and characterization of SOL. And there are many brain tumors that on the basis of location and typical characteristics in MRI can be diagnosed without any biopsy, so that we can proceed with further treatment. So others are pain in bones and joints. Fifth warning sign. This may be a primary symptom for tumors that involve the bone or bone marrow, like primary or metastatic bone tumors, leukemia, neuroblastoma. These are actually caused by infiltration of the bone by tumor or nerve or visceral involvement or encroachment. This may be the early symptom of malignancy involving bones like Ewing's sarcoma, osteosarcoma. This may have duration of several weeks to months and typically begins at intermittent pain and increasing severity over time and may have waxing and waning course. And there may be associated marks that may be palpable on examination, but initially the child may have just pain in the legs and that may be ignored for months even. So when we say that this is sinister and this can suggest a malignancy. So if a bone or joint pain is persistent and its nocturnal pain consistently wakes a child from sleep at night, there is pain at rest, or the bone or hip pain in a young child that is always abnormal, or recurring progressive pain or limb that makes the child unable to walk after with duration of time, and a pain associated with swelling or mass examination, and that is not related by NSAIDs. Actually, this pain is so severe that may not respond to any NSAID and may require opioids. So there are some confounding factors that are also there that may actually make diagnosis of this difficult. There is history of congenital trauma that causes fracture. Actually, those may be pathological fractures that are commonly seen in Ewing sarcoma, osteosarcoma in 10 to 15% of cases. So these children, they come with pain in legs, and when on X-ray we see a trauma, we see a fracture that is actually a pathological fracture that is associated with some other abnormality in the bone. And they may actually think that this may be because of trauma, but generally such a trivial trauma will not lead to fractures if the bone is normal. So there is, if there is associated fever and congestion symptoms, particularly Ewing sarcoma, osteomyelitis must be considered in different diagnosis of such cases. Osteosarcoma may not have fever at all during presentation. The other diseases like rheumatic diseases and COX have been ruled out because these are much more common than malignancy. Then when should we actually do a bone marrow examination in these cases? If there is the type and the severity of pain is atypical of rheumatologic origin, like these are not actually joint pains, they're actually bony pains. There is no history of any rashes or any other immunological problem in the child, then we should think of doing a bone marrow biopsy. If there is progressive pain and child refuses to weight bearing over time, there is as well as cytopenias in CBC, and there is elevated LDH. These are signs we should go for a biopsy before starting any treatment. Like GIA can be a very big confounding factor while diagnosing leukemia, because many cases of GIA, they are started on steroids and with time they don't respond, and when it's further evaluated in a bone marrow, they come out to be turned out to be leukemias. So before starting, so in many situations, this is a like dictum that before starting steroids, if in suspected case of GIA, we should do a bone marrow to rule out leukemias. So evaluation, coming evaluation in these cases, we should do general evaluation like plain radiograph of the chest, CBC with differentials, CRP, ESR, alkaline phosphatase, LDH, uric acid and all. So in these cases of leukemias or malignancies, this lactate dehydrogenase and uric acid, these are quite raised because of the high turnover cells. So these are quite indicative of that the cell turnover is quite high. So plain radiograph typically obtained as initial imaging study. However, this may actually give you some diagnosis like mediastinal mass and all. MRI is generally performed preferred modality for definitive evaluation of bones and soft tissue lesions. So in these cases of osteosarcoma, Ewing sarcoma, we generally we go for X-ray of the bones first, because this gives you initial clue. And when we have this diagnosis that this is some malignancy, we should go for a MRI for evaluation further. Just because MRI will give you a better picture of the associated soft tissue, associated neurovascular bundle involvement, and associated marrow involvement, and it actually gives you a better picture of the where we should do a biopsy, and for where we should go for surgery and all. So there are some typical signs that we get in bone tumors in cases of in this X-rays. Like this is a picture of Codman triangle. This is a case of osteosarcoma, and this Codman triangle actually results from the soft tissue mass sticking to the overlying ossified periosteal new bone formation, and that is frequently present in osteosarcoma, Ewing sarcoma. You can see a triangle there that is periosteally elevated because of the increased turnover of the bony mass from beneath, and this is breaking the periosteum. Second is onion skinning. This is because you can see there is different layers of the periosteum. That these layers are formed if a tumor is quite indolent. That is, there is different phases of breakage of bone that lifts the periosteum again and again, and this forms different layer of periosteum. That is typically seen in Ewing sarcoma and generally not seen in osteosarcomas. Come to sunburst appearance. This is seen in aggressive tumors, mostly in osteosarcomas. This is because the bones are proliferating so much that they invade the soft tissue surrounding, and this gives a picture of sunburst. In leukemia, what we find is osteopenia, lytic lesions, metaphyseal bands, and periosteal new bone formation and sclerotal lesions. That is found commonly in leukemias. So, to imaging, MRI is the preferred modality of for different evaluation of the bone as well as soft tissue, including bone marrow invasion and the neurovascular bundle. And PET and bone scan are done to complete metastatic workup. So, if we want to do the biopsy of the mass, we should actually involve the orthopedic onco-surgeon who is going to be associated with this case throughout, because while going for surgery post chemotherapy, we have to take the tract out along with this mass. So this is very important that it has to be done under supervision of the orthopedic onco-surgeon, because he should be knowing that where he has taken the biopsy from. So coming to sixth sign that the child presents cancer is mediastinal mass. So this is commonly discovered on chest radiographs obtained for other reasons, maybe asymptomatic in many cases of benign masses, and few indolent malignancies like Hodgkin lymphoma. May be symptomatic with cough, shortness of breath, often positional, hoarseness of voice, wheezing, engorged neck pain, suppression of face, or swelling of upper limb. That is called as superior vena cava syndrome. These are red flag signs and require emergent treatment. So, very important thing is any mediastinal mass that we come across in imaging in chest radiograph needs evaluation. And just few masses like that are commonly found in child, like thymic mass may not require any, because these are commonly seen and can be diagnosed on a chest X-ray very easily. So ED mass, other than this, actually should be evaluated. So these are some common mediastinal masses that we come across in children. So when you go for supremediastinum, the most common malignancy we see is leukemia and lymphomas. In endomediastinum, the leukemia lymphoma is the most common. After that, there are GCTs like teratomas, Yorkshire tumors, choriocarcinoma, and mixed GCTs. Thymic tumors and thyroid masses are also there. In the middle mediastinum, again, the leukemia and lymphoma are most common, followed by cardiac tumors and soft sarcomas. And in posterior mediastinum, the masses that are more common are those arising from the sympathetic channels like neuroblastoma, and bone tumors like Ewing sarcoma. So children with malignant tumors, they more commonly present with malaise, neck swelling, abnormal extracurricular lymphadenopathy, and or hematologic malignancy like cytopenia. So it becomes a bit indicative that if these are present, the child may be having a malignant mass. So coming to evaluation, all masses that are in mediastinum require further diagnostic imaging, generally a CT chest, and this CT generally identifies benign conditions and thus avoid invasive procedures. If we suspect a malignancy, then we should go for a MRI or PET CT or integrated PET-CT so that we can know the extension, invasion, and metastasis, and oncologist should be informed or referred to for bone examination or tissue examination, tissue biopsy if indicated, so that we can diagnose malignancy. So coming to abdominal masses, this is most commonly that we come across abdominal masses is like when a caregiver detects it accidentally while giving a bath or caring for the baby. So this may be benign and frequently asymptomatic, but all the masses that are there in abdomen should be thoroughly worked up and considered a red flag sign if they don't fit into common explainable non-malignant settings, like a case of malaria or typhoid. They may present with hepatomegaly, splenomegaly, and we can diagnose them quite easily and treat them. But if this is not the thing, then actually we should evaluate each and every abdominal mass. So any mass that we see in abdomen, like hepatomegaly, splenomegaly, or bladder kidney or bladder, if they can be explained with non-malignant settings, they are managed first on recommended lines. But if not, they should be actually investigated. So the mass is generally present with pain, vomiting, constipation, less commonly intestinal obstruction, painless hematuria, and many are asymptomatic ones. So what are common intraabdominal tumors? The commoner are Wilms tumor, neuroblastoma, and buccal lymphoma. So age-wise, we go, then the youngest one, they generally present with buccal lymphoma, and if we come further, then Wilms tumor, RMS, rhabdoid are common. And after that, in maybe adolescents and all, buccal lymphoma is the most common abdominal tumor that we come across. Others are lymphoblastic leukemia infiltrating to viscera, lymphomas, hepatoblastoma, germ cell tumors, and soft sarcomas. GCTs are much more common in adolescent age group and as the age increases. So how to evaluate? So if a child comes with abdominal mass, we should take a proper history and we should ask for symptom related to the mass, and if so, duration and intensity of the symptoms. It actually helps to determine how rapidly the mass is growing and or to distinguish malignancy from another mere chronic condition. Like a buccal lymphoma has a doubling time of maybe 20 to 24 hours. So if a child has got buccal lymphoma, he may give a history of just few days to 1 to 2 weeks, so that and this mass has grown so big. So we should take the proper history, how the mass is growing. We should also take the associated genitourinary symptoms and signs like painless hematuria and menstrual history in girls. And we should also check for the testicular enlargement, because many abdominal masses like GCTs may have a primary in testis, and even leukemias, lymphomas, if they also present with testicular enlargement. And we also should also look for location, extension, laterality, and mobility of the mass. Like a midline mass can be GCT, lateral mass can be a Wilms tumor or neuroblastoma, and if it generally crosses midline, it can be neuroblastoma, can be a hepatoblastoma, can be some splenic tumor. So second thing is we should go, take the vitals, especially BP, that is generally raised in neuroblastoma, renal tumors. Lab studies would include hemogram, biochemistry, including TLS parameters like potassium, phosphate, then uric acid, creatinine, and all. We should also go for tumor markers like LDH, serum AFP, beta HCG, and serum ferritin. This LDH and ferritin, they generally increased in this neuroblastoma. LDH is seen in increase in lymphomas, leukemias. AFP and beta HCG are generally increased in this germ cell tumors, and a very serum AFP, very high serum AFP is seen in hepatoblastomas. So this will also indicate the location of the tumor, the organ that is involved. And coming to imaging, generally USG is the first and foremost imaging modality that we typically use for an abdominal tumor. And depending on that, to further characterize, we can go for additional imaging with CT, PET scan, MRI whenever warranted. Coming to soft tissue mass, any soft tissue mass anywhere in the body, extremities, head and neck, face or trunk, without a traumatic explanation, needs to be evaluated. So what are red flag signs? Like when should we actually investigate a soft tissue mass? Any mass at new in onset and is steadily increasing in size, like the mass was there for many years and so, and it was normal, it was not increasing size, but has suddenly started increasing in size. A mass that locally infiltrative and disfiguring is relatively non-tender and firm to high consistency. These are signs that this mass should be evaluated for cancer. So what do we do? So preferably a local mass before any intervention should go for a MRI, because if this mass is small, this will help you take a surgical margins so that we can get a clear margin. And so before going for any surgical procedure, we should go for a MRI. Like if a mass is very infiltrative, actually it precludes any surgery. And it will require chemotherapy and all before a surgery can be attempted on this. So if we get a mass, then we should go for a biopsy of the mass by either excision or true-cut or immediate core biopsy as indicated. FNAC generally advised by many clinicians, but it has got a very limited value and is not recommended as a diagnostic tool, because this FNAC, if it is done, it may not be representative of the tumor, and it may be from an area where there is no malignancy. So actually, this may lead to a false negative result. Coming to other, the most very important thing is hematological abnormalities. This is the most common genetic feature in child malignancy that is seen in like leukemias that are most common in younger children. So anemia, leukopenia, leukocytosis, thrombocytopenia, they are often occur in leukemias. And marrow infiltration by other tumors like neuroblastoma, lymphoma, Ewing sarcoma, RMS, they lead to leukoerythroplastic pictures in PBS that we see immature cells coming from the marrow pushed into the peripheral blood. So in these cases, when should we go for a bone marrow examination? When should we refer the child to oncologist? So any finding of blast cells on PBS, a total WBC count of more than 1 lakh is a different indication. A child count more than 50,000 may be associated with leukemia reaction, but should be evaluated. Any significant depression of multiple cell lines or at least 2 cell lines without obvious explanation. If this is associated with lymphadenopathy or hepatomegaly, this should be actually thought of. Any associated with abdominal or mediastinal mass or absence of other explanations like infectious disease for blood abnormalities. So we should actually do a bone marrow examination for this. There are several cancer predisposition syndromes that the child may have, and we should actually screen these children for malignancy. Like familial causes are like trisomy, familial genetic or abnormalities like trisomy 21, neurofibrosis, familial polyposis, Lee-Froment syndrome, or retinoblastoma. This actually are cancerous, they have a cancer predisposition in these cases. There are many immunodeficiencies or metabolic disorders that present with cancer, and a previous history of cancer needing cancer therapy or radiotherapy, they should also screen for a secondary cancer. So, coming to few case discussion. So there are 3 cases I have put forward that are not exactly typical to presentation, typical presentation for malignancy. So I'll discuss these cases one by one. So a single term male, AGA 2.5 kg baby, born by normal vaginal delivery, born to 35-year-old primary gravida, died immediately after birth with active score of 6, 8, and 9. Anterior USG had atrioventricular septal defect, no prenatal or perinatal complication. On day 4, presented with decreasing urine output. On examination, he had Down's phenotype. And in labs, there were deranged RFTs. Urea was 103 milligram per deciliter. Creatinine was 2.8. In biochemistry, there was raised phosphate, low calcium, and uric acid was quite raised, of 40 milligram per deciliter, and electrolytes were normal. When we did a CBC, there was a total count of 1,58,000. Platelet was 95,000. Hemoglobin was 9 gram per deciliter. So there was increased TLS parameters with abnormal CBC with hyperleukocytosis with low platelets and low HP. When we did the peripheral smear, it has 18% blast, and in flow cytometry, these were of myeloid origin. So this is actually not very common, but this is called transient abnormal myelopoiesis that are generally seen in 4 to 10% of neonates with Down syndrome. This is very specific to Down syndrome because of data mutation that is present in them. And this generally resolves spontaneously over a period of several weeks to 3 months. But these cases should be followed up, as in 20 to 30% of them, this may actually develop AMKL, that is acute myelokaryocytic leukemia, in 1 to 3 years of coming 1 to 3 years. So a child with who is presenting with TAM should be followed up every 3 months till 3 years of age for progression into the AMKL. Coming to case 2, a 15-month-old boy presenting with right ear discharge and seborrheic dermatitis that are not resolving since 6 months of age, fever and jaundice for 1 month, rashes on the scalp for last few months. On examination, anthropometry was appropriate for age, for all the parameters were within 50th to 70th percentile. Child was febrile, icteric, and there was no lymph node enlargement. Multiple infiltrative skin lesions were observed on the scalp and back, and lesion was raised, mobile, not attached to underlying structures, and were non-tender. So there was central perforation in the ear drum, and there were non-foul smelling discharge. On peritoneal examination, there was smooth, non-tender, non-pulsatile hepatomegaly, which was palpated 3 cm below the left posterior margin. There was firm splenomegaly, and there was septic dullness. In CBC, there was normal parameters were there, and in bilirubin, in LFT, bilirubin was 10.1 with ALP of 3495 and GT of 210. LDH was high of 402. We did a BMA, and there was mild plasmacytosis. These two processes that may be there because of hepatic disease, but there was no evidence of metastasis, and CS was normal. CT abdomen showed moderate hepatomegaly with 3 portal hyperdensities extending into the all portal radicals. There are portal fibrosis. So lateral lesions of the right iliac crest was also noted. In bone scan, there was oval photogenic area surrounded by a rim of mildly increased radiotracer over the right parietal bone and both of the iliac bones. So what can be diagnosis in this? Anyone?
LCH with
Yeah.
the risk organ positive and CNS risk positive.
Yes, sir. Yes, sir. You are right. So this was so we did the biopsy of bone scalp lesion, and this was infiltrated of larger cells with abundant cytoplasm with convoluted or turniform nuclei, and ISC showed CD1A positive and S100 positive histiocytic cells. This was LCH. It is organ positive. So a third case, a 6-month-old boy presented with history of anisocoria. Examination, small pupil on the left side, but there was no ptosis. Mother reported that pupil was sometime normal in size. So he went to an ophthalmologist, and the no tests were ordered and was asked to observe. Again, after 1 week, the mother observed that there was occurrence of ptosis on the first time. For the first time, it was on the same side. This was actually horror scene. You can see this is a repetitive picture. You can see there is ptosis and ptosis of the left eye of the biosis. So this is Horner syndrome. So what kind of diagnosis in a child, in a 6-month-old child presenting with Horner syndrome at this age? So what should we do further? What can we think of? Okay. So the child was advised CT of thorax and neck, and it revealed a paravertebral mass with calcification thorax region that excised completely and sensitive of the biopsy was neuroblastoma. So this is very common thing. Child neuroblastoma presenting in neck and head and neck and thorax region actually may present with Horner syndrome because of the involvement of sympathetic trunk. So this generally has a good prognosis. They are not high risk neuroblastomas, and this Horner syndrome may have a waxing and waning course, and it's managed conservatively. These patients also may have obstacular macular syndrome presenting a feature in infancy. So these children may have neuroblastoma, and that is managed just with surgery and observation. The OMAS and Horner syndrome has to be managed conservatively only. There is no particular treatment for them. So coming to cancer survival trend over the last 50 years, if you can see that in 1973, the survival from cancer was anything between 50 to 80%, and as we have progressed over the last 50 years, the cancer survival has gone even up to 5-year survival has gone up to 70% to 80% even. So we can see that with the treatment, with advances in technologies, with advances in treatment, the cancer survival is increasing with time. And this is very important that if a child is suspected to have cancer, then only we can actually start treatment early, and we can actually give new life to the child. This is very important that you should actually think of cancer in a child when these signs symptoms are present, and should refer to an oncologist. So survival rate in children 0 to 14 years has improved dramatically since 1960s. That was initial 28% and has gone to 80 to 90% right now. And so this data says that in children diagnosed with leukemia, malignancies from 2005 to 2006 had a overall survival of 80% at 10 years. So what I would like to give a take-home message is, any sign and symptoms in childhood cancers are very common to other childhood illnesses, but should be with these red flag signs, but should be thought of. And early diagnosis of cancer may improve outcome. And if the possibility of cancer is not considered, delayed diagnosis is the result. And although the incidence of cancer is quite low in childhood, the impact of cancer makes it imperative that all the professionals have a high suspicion for cancer. So I hope this was helpful to you. If you have any questions, I'm open for it.
Any questions from the audience? Okay, so I think we are ready with our questions. Sagnik, are there? Can we start our quiz?
Can we hold just 1 second, ma'am? I'll confirm the quiz details and I'll get back to you.
Yeah.
Just give me 3 minutes. I'm returning back to you. I'm reverting back. 1 second.
Anyone in the audience is working with pediatric oncology department or is getting pediatric oncology patients?
Madam, I am Dr. Atul. I am from Karnataka. I am practicing pediatric oncology in a place called Bijapur in North Karnataka.
Okay. So do you face any problems with diagnosis, getting patients, any in the treatment line, anywhere do you face any of the problems?
Yes, ma'am. The issue is we don't have a flow cytometry machine, ma'am. We have to send to a places called Sangli, Miraj, or at least Mumbai. We have to send to get a flow cytometry report, because to Bangalore is a little far away from this place. So only is Sholapur is the nearest place to us where we send flow cytometry.
Okay.
That is the thing that's getting delayed. And one question from my side is to sir. One query is there, ma'am. Can I ask?
Dr.
Yeah,
Amit,
sure.
right?
Sure,
You can
sure.
ask, sure. You can go ahead. Dr. Amit, you're there, right?
Yeah.
Sir, recently we had one case, 6-year-old who presented with epistaxis and gum bleeding.
Okay.
The child did not have lymphadenopathy or any mediastinal mass, bone tenderness, or any organomegaly, no petechia, no purpura, no ecchymosis. There were no other bleeding manifestations, so unless only the symptoms for epistaxis and gum bleeding. When CBC was done, it showed hemoglobin of 2. Total count of 10,000, sir. Neutrophils were 64%, lymphocytes were 36%. Others were normal. Platelet count was 2,35,000. We had PTA, PTT-INR, that is normal, sir. Then we pH was 155. Then suspecting iron deficiency anemia, we had done serum iron profile, which showed serum iron less than 10, ferritin 5, and total iron binding capacity of 400, sir.
Okay.
Suspecting leukemia, we did the bone marrow. Bone marrow showed all the cell lines had normal maturation, sir. No blasts were there. And when pearl stain was put, it showed again iron deficiency only.
Okay.
So we are not able to find out why there is such a severe anemia just because of gum bleeding and epistaxis since only 6 months.
What is the age of child?
6 years, sir.
6 years. And did you look for any chronic infections, anything that may be there, or did you look for parvovirus and all?
No, sir. Parvovirus we haven't done. Retic count is 0.7, sir.
Okay,
Very
0.7. It's not increased. So actually, we should also look for EBV, EBV and parvovirus and CMV and all, because generally, this bone marrow did not see a sign of aplastic anemia. There was no hypoplasia in bone marrow.
no, sir. No hyperplasia. It was
no hypoplasia, no hypoplastic. It was not a hypoplastic marrow also.
no, sir. Not hypoplastic marrow. So we were. So we have referred, sir. Currently, as we were not able to find the cause.
Okay.
Even the patients were worried. So currently, we have referred. Whether any platelet aggregation tests we have to do, sir? Whether any normal platelet count with bleeding stress?
Dr. Atul, actually, I'm a pediatric oncologist, not hematologist. So,
Okay.
So that is the thing. So, Dr. Juhi is there? Hello.
Doctor.
Yeah, I'm there.
To comment, yeah.
So, do you think you can help in this?
So I think your suggestion for the viral workup was right for the paro and thing, but I don't know why a child with a low hemoglobin and normal platelet should present with epistaxis.
That is the thing.
First of all, platelet counts are normal, so we should work up. And you said the coagulation was normal, right?
Normal.
So first of all, a child with a very low anemia will never present with epistaxis. An iron deficiency presenting with epistaxis and bleeding manifestations is a little odd.
Yes.
So there is definitely something underlying that is ongoing.
Yeah.
And it's not looking like a straightforward iron deficiency for sure.
Okay. Was there any history of viral infections? See, like
fever or
and all
anything before that?
Fever history is not there, ma'am. The only presenting feature was lethargy and fatigue. Early fatigue was the.
And what about clinically? Was there any lymphadenopathy, hepatosplenomegaly?
No lymphadenopathy, no splenomegaly.
So recently, I have come across a case of herpes simplex that was there in a person, not a child actually. So he also had this nasal bleed consistently, and he had platelet count of 50,000-60,000. So we thought this was because of low platelets and all. So we could not find anything, even after giving platelets and after multiple nasal packing, this bleeding did not stop. Then what we did a CT angio, and there was an endarteritis. That was because of the herpes simplex. So if there is local bleed only, there is no bleeding for any other side. Actually, can we just look for a bleeder for that, or either any history of iron infection that may cause endarteritis and that may cause this bleeding from this artery? So this is one thing I can think of. And obvious HP was quite low, but marrow is normal.
Yes, sir. So
this is because of chronic bleed and PBS. What was there in PBS? Peripheral smear?
Peripheral smear showed microcytic hypochromic anemia, sir, with a few megakaryocytes, and platelet morphology was normal. Then that's it. And a severe degree of anastopocytosis and target cells, and 2+ were the cystocytes, sir.
Cystocytes are 2+.
2+.
Any chance could be there be anatomical lesion or something? I don't know. I mean, I can't comment on medical side, but is there anything of some lesion which is causing epistaxis?
And cystocyte, why should there be cystocytes? Cystocytes are generally because of hemolysis and all. There's some
Okay.
peripheral hemolysis going on.
Okay.
Yeah, no hemolysis. LDH is to 155, sir.
Okay.
And that we currently, though, we have started on ferrous ascorbate, sir. We are looking
Okay.
for diuretic response after 14 days. That's what we had told and discharged. So,
Okay. And what is the further, any further progress in that? Where have you referred to?
we have, sir, I have done my fellowship in oncology from KMC Manipal, sir. So I
Okay,
have referred
you have referred to Manipal only?
Manipal only, sir. Bangalore Manipal or KMC Manipal I have referred to.
Okay. It would be good if you can update us with this case.
Sure, sir. Sure.
We'll be getting feedback. So probably we'll be sending feedback email soon. So we'll see how we can connect you.
Sure.
But sure, we'd like to know what is the update regarding the case. I can see Dr. Geeta also and Dr. Ruchi. You have any questions? You want to get ask any questions or something? Okay.
Sorry. Good evening, ma'am. I'm Dr. Geeta. I'm from Karnataka. I'm oromaxillofacial surgeon. We had
Okay.
one patient since 2012 to till now, 36-year-old now. He is having the same problem, ma'am. Might be it is vascular issue related.
Okay.
He has undergone multiple scans actually.
Okay.
Only he has undergone one scan with multiple doctors' opinion actually.
Okay.
So I had referred him for repeat PET scan came negative, ma'am, no cancer.
Okay.
Actually, if you allow me, I will send the details to some email because 52 pages are there, ma'am, that records. They told it is inferior turbinate hypertrophy, but I don't think so. 36-year male patient, he needs a little bit a neuro skull base surgeon opinion actually. He
Okay.
needs a ligation of some artery, I think so. So I have sent to tertiary care center. If you allow me, I will send the details the papers which has undergone investigations. Blood counts are normal, ma'am.
Okay.
Okay.
So probably
Yes,
some
sir.
radiation or something has been done, which has caused some vasculature, which is like post radiation, the vessels have become thinned out or something like that. Was he? Did he get radiation also?
No, ma'am. No, ma'am. Since 2012, he started epitaxis on sneezing and on coughing. And he told me recently it is increased. Recently, the frequency of blood loss is increased. So he showed me scan reports, sir, ma'am, and he showed multiple doctors' opinion. Overall, he needs some ligation of some main artery, sphenopalatine, I think so. So I've sent him to skull base surgeon. If you give me email, I will send the details so that we can do something for that patient. He was not able to offer. He goes a little bit late for after collecting money, he will go for scan and all. Some financial
So
issue was there.
we'll try and help you out if we can in any way.
Yes, ma'am.
Share
Yes,
our
yes, ma'am.
ID and you can send scans.
Ma'am, he has undergone blood investigation also. All are normal, ma'am. Only epitaxis might be vascular issues related. Late stages of middle age complication might have got started from 2012 till now. 10 years he is suffering from that.
Okay. So we'll try and
Yes, ma'am.
yeah.
Ma'am, if you send me email, I can share the details with you, ma'am, like other doctors.
Sure. I'll send you.
Yes, ma'am.
Yeah. Anything else from anyone? So Dr. Amit, very nice lecture. Even I was listening to all the red flags. So probably it will help us. And thank you everyone who could join us in the lecture series. Thank you, Dr. Amit.
Thanks a lot.
Dr. Juhi also. Thank you, Dr. Juhi, for helping us out. Yeah.
Thanks for inviting.
Thank you, everyone. Thank you.
Thank you, ma'am. Thank you, ma'am.